PVC and urethane, and so also what some of the differences are and the benefits are for those products, and also some of the history of why urethane materials were used originally. I'm going to go over cannula flow performance and testing with pressure drop charts. Most of you are very familiar with pressure drop charts, and you use those in order to compare different cannula to each other. Most of you probably aren't aware of how those charts are generated. So we used to, many, many years ago, do those with graduated cylinders, so very much a laboratory type of setting. We still have a laboratory setting, but it's actually a computerized flow bench, and I'll show you a little video on how that works as well, because that's a question we often get. I'm going to talk a little bit about the cannula industry, because there is a lot of things going on globally in regulatory environment, both in Europe and US as well as other countries, that is impacting some of the cannula manufacturers. I'm going to give you a little bit of a talk there on what's happening in the regulatory side. Cannulation techniques for minimally invasive, because certainly the small incision valve procedures with femoral and percutaneous peripheral cannulation is certainly a growing segment, so we'll talk about that. And then a little bit about specifically our more recent femoral cannula products, so a little bit about our actual products. That's a bit of a feature benefit talks to help you understand what the reason that we've created the newest versions of Biomedica's cannula are. So with that, we'll start out first with sort of the history. And most of you, I say history, but some of these cannula that were really just extruded tubings that were with secondary processes of holes cutting and beveled tips and rounding of the tips with heat processes. These are pretty simple cannula that were made and produced many years ago and still produced today. We still make models that are very simple technologies like this. They do not have the kink resistance that more modern wire-wound cannula do. They don't have a lot of the features in the tips, but they do have a very low manufacturing cost, and so these products we still sell in many places around the globe. Also, the other side of this is, of course, the metal tips. And can I see a show of hands? Does anybody remember the old metal tips, right? And do anybody still have the old metal tips? And when I say this, I don't mean metal tip cannula. I'm talking about the metal tips that you just push onto a piece of tubing, right? So if some centers are still using those. You know, those are probably declining significantly in use because of the burden of having to re-sterilize and clean these. But you can see there's a picture on the right. I actually will credit this one to Mayo, because Mayo many years ago were using all sorts of tips like this. And in fact, I think they only stopped doing that about a decade ago. So there are some benefits to having these types of tips and having many, many sizes. Sometimes in the pediatric sizes, very small sizes are beneficial. However, it does have some certain drawbacks. I should say, though, before I jump too far ahead on the metal tips, of course, we still do manufacture metal tip venous cannula that have a body on them. And are intended to be a disposable product. And there are, of course, metal tip arterial cannulas. So they do, one benefit you do get with a metal tip is thin wall. So the component manufacturing, so we've talked first about the bodies. On the left side, you can see an illustration to show you how an extruding die works. And this is how all the tubing that you use in all of your circuit components as well is made, is through an extrusion process that allows you to extrude a tube, but it does not allow you to change the diameter during the extrusion. There are ways to do that in pulse extrusion, but you can only do that in very limited ways. So you end up with a very restricted ID and OD of the same diameter for greater length. And that's a very useful thing to be able to have an extrusion to make tubing. But when you make a cannula body that way, the cannula body ends up being a very restricted size diameter, and so you have a greater pressure drop from one end of the cannula to the other. Whereas if you actually manufacture it in different methods, which we'll talk about shortly here, you can have a tapered body that will give you a better flow performance and a lower pressure drop. On the right-hand side, you'll see the injection molding illustration. And this is all of the little tips and pieces and connectors on the back end. So all of the components that you see that are separate components of PVC, and they may be a softer PVC and pliable, or they may be a more rigid PVC. But injection molding allows us to have complete control over shapes of the cannula. I'm sure many of you have seen tips of cannula that are intended for diffusion or dispersion of flow, and those are very complex shapes in that tip itself. That's created by an injection molding process, and then that tip is bonded onto a cannula body. So many, many components today are still, of course, made by injection molding. And I think I'm going to start on the right side of this slide because this is sort of a representation of where dip molding used to be. So dip molding, which again allows you to have a cannula that's shaped without a bonded junction, right? So if you all remember the, I'll call it what the product manager for the William and Harvey, or the Bard cannula used to call them, is the champagne colored cannula, right, on the right hand side. That was the state of the art of PVC dip molding in its time about 30 years ago. And so that was the state of where PVC was. You didn't get the clarity that you do today of the actual PVC material, so you couldn't see into the cannula very well. And you also didn't get the softness or the pliability of the PVC at that time. But what you did get was a small French-sized tip and a larger body area, so that you would have a larger body area improving your flow performance before the restriction would happen at the tip of the cannula. And that was actually, of course, an old Bard femoral cannula. People used it as a femoral arterial cannula, not intended to be placed all the way up past the bifurcation, but just in the femoral artery. But that also was used very commonly as an aortic cannula. And on the right side, more of a TMP Argyle style cannula, which was again also a dip molded, tapered cannula. And the dip molding process is a little bit like reverse candle making. Essentially, you'd have a stainless steel rod, or what we call a mandrel, that's highly polished, and it represents the entire taper and shape of that ID of the cannula, the internal diameter of the cannula. So that then is dipped in liquid plastisol in PVC, could also be urethane, and that is then cured in an oven, and then it's dipped again, and then cured in the oven, and so you end up with a layered but integral body wall cannula that has a shape to it. On the left-hand side, you see the results of more modern technology. These are actually two of our cannula that are a PVC dip molded cannula, but include a stainless steel spring or wire reinforcement. So that process of dipping onto the mandrel, curing it, dipping, curing it, after about 2 or 3 dips, there is a stainless steel wire placed around that, and then it continues to be dipped another 3rd or 4th time and 5th time perhaps. And so what happens is you end up with layers of PVC that integrates that spring into the wall of the cannula. So it's not going to move in the wall and migrate. And so this gives us the kink resistance, and also the materials today have far better clarity and also are far thinner. So the illustration, the picture, I'm sorry, on the bottom left of the slide there is actually a cannula on the left-hand side, which is a higher durometer PVC. That's a dip molded cannula, and another cannula from about 15 years ago of PVC dip molding technology. So you can see that over time, the plastic science has allowed us to have a higher durometer, thinner wall. So for the same French size, outer diameter French size, we can have a larger inner diameter flow space, and again, improving performance. The other material that was very common and still is very common for cannula is actually a urethane material. And most of you probably remember, and some of you may still use, because we certainly still sell some of these, is the DLP on the top, the femoral cannula. This was a extruded urethane, and so there was no wire winding in this. It is very similar material to what you see as introducer material in many femoral and percutaneous cannula, but the cannula itself was also the white extruded urethane material. And that material then was bonded on to clamp site areas that were softer PVC and connectors. There's another method as well, and we had a product for some time below that, the smaller cannula you see in the middle of that slide. And that was actually an extruded urethane cannula as well, but it had an extruded wire winding, but so instead of being dip molding, it was extruded. But because it was extruded, there was no taper in the body of the cannula. It required that it be the same French size the entire length and then a clamp site. And this is actually the way there are a couple of competitors who still sell cannula like this in the industry, and they are a good thin wall, good flowing cannula with the only restriction being that the French size has to be the same for the entire length, which does provide some flow restriction. And on the bottom, a picture of our multi-stage Biomedicus cannula. So Biomedicus is a bit unique. It is a dip-molded urethane cannula. It was actually the first dip-molded urethane. And the benefits of urethane are several. One is it does not contain any plasticizers, so therefore it doesn't contain phthalates. That also means that it will not leach phthalates. So PVC cannula, when they are left in for longer use, and by the way, none of the cannula we've discussed today and none of our products today are indicated for long-term use or ECMO use, not even for VAD use, because particularly PVC cannula will leach plasticizers. They will become somewhat discolored, but they will also become more rigid. And so there is risk in that, and that's why urethane cannula were originally introduced, is because the durability and flexibility that they maintain, they don't leach plasticizers and become rigid because they don't have any plasticizers to begin with. So urethane cannula are actually more expensive. The material is more expensive, and the process yields fewer cannula that don't have air bubbles and things through the dip molding process. And so it's a very yield-intensive process and a much more expensive product with a much more expensive material. However, it allows you, because it's very dense material, to have a very, very thin wall. In fact, in the Biomedicus product line, the wire that's in the wall is actually a flat ribbon shape. It's not a round wire, so it's a flatter wire. And that, again, allows the wall to be even thinner, and that's why you see that the pitch is very tight, and you can't see between the coils of the wire themselves. So again, urethane dip molding certainly gives a lot of benefits. I want to talk a little bit about flow performance and flow charts. So as I mentioned, we don't do it with a graduated cylinder on the bench in the lab anymore. We've done it many, many years now with a computerized flow bench. And it does give you the ability over several runs and we do test different products of the same manufacturer and at usually 3 times each. And so we're making sure that we're getting good averaging data for the performance. But it is actually a tank that is allowing the water. We always do our tests with water, and also all the current manufacturers on the market that sell cannula for cardiopulmonary bypass do water testing. So you might ask, why would you bother doing water testing when we know that blood, right, will have a higher viscosity, a greater thickness, right? And so it will therefore have a different performance. And the answer is that it's easiest to compare cannula when everyone is doing water testing. And so the entire industry does water testing at room temperature. And although you'd have very, very slight differences if you were in Denver, Colorado, or here in South Florida, just because of elevation, you do have now much more comparable data charts to compare one cannula to the next. I'm going to see if I can get the video to run quickly. Where is that? Didn't have to do that the first time.
Video settings. You have it set in like extended mode now. Actually, I think if we just close this PowerPoint.
Yeah, that's the one I'm using.
I know.
Yeah.
But if you close it, I think it might. Can you get back into it? Is that okay?
Sure, I can.
Now it should display your desktop.
All right.
It will in a second, I think. There we go.
Okay.
This brief video demonstrates computerized testing of Medtronic cannula products to document flow performance efficiency. Cannula are placed in the test fixture to provide flow of water through the cannula in the direction that blood would also flow during normal use. Here we see an arterial cannula placed in the test fixture to flow from the connector at the source tank to the cannula tip.
Throughout the test cycle, the flow rate is increased and data points are collected on the differential between the pressure in the source tank and the open end of the cannula. The test station then graphs this data into the pressure drop performance charts.
The test station setup is easily adapted to allow flow through a venous cannula from the tip toward the connector end, as seen here for this two-stage or cavo-atrial style venous cannula. Again, we see that the testing cycle gradually measures flow while continually tracking pressure. After the desired flow rate is achieved, the recorded measurements are used to plot a graph illustrating the pressure drop performance of that type and size of cannula.
I'm not getting my folder back up. Yeah, I'm trying to get the folder to open back up, and it's not coming up.
Can you open anything?
Not at the moment.
There we go.
I have no idea why.
I don't either.
I'm going to try to shut down and restart.
You,
Let's try that.
here, I'm just gonna do it this way. Is this your last one?
Yeah. There it goes. Awesome, thank you. Sorry for the delay. Okay, so the next topic is so the cannula industry issues. So Medtronic sells cannula, our cannula products in over 100 countries globally, every country that does cardiac surgery. And we are very happy to have a very large market share. We have greater than 50% market share globally, and certainly within Western Europe and the US, that's also true. There have been some regulatory issues recently that have impacted the industry, our competitors, and us as well. We have had, as most of you know, at least one competitor based out of the US about 3.5 years ago who left the market entirely, and that was because of some issues with FDA that have also impacted all of the other competitors. We've had another significant competitor, probably our the second largest player in the industry, our major competitor, who have pulled and removed complete product groups off the market. And again, we could make a guess, we don't know for sure, that may also have been motivated by some regulatory pressures and some additional expense and costs in order to maintain regulatory submissions. We do know that in Europe, there is now implementing what's called the MDR, and it implements this year, and that's a difference from the old MDD. So they're going from the Medical Device Directive to what's now the Medical Device Registration. And this registration, this regulatory change, means that cannula in Europe are now treated as a Class 3 product. So they are essentially treated exactly the same as an implantable device. Quite a difference in looking at the registration. And the TGA, the Therapeutic Goods Administration in Australia, actually was the first regulatory body in the world to implement this Class 3 change for cannula. This has led, as I'm aware, several of our competitors who have more of a base for their operations in Europe to say that they are getting out of the cannula business. And so there are a couple of smaller competitors and also ones who are involved with both cardiopulmonary and cannula who have decided that the cannula business is going to be too expensive for them to remain in and have made that statement even in Europe because of the MDR changes. So I think that's something that I think everyone needs to be aware of, is the regulatory changes are changing the environment for us and also for our competitors. The CE certification then will require a great deal more registration data, engineering data, testing data, which of course we've always had fairly high barriers for those types of data submissions for the FDA and for CE mark. But it is changing significantly, and it's requiring millions of dollars of investment in the industry, in our case, across our product lines in cannula and cardiopulmonary on a yearly basis for probably the next 4 or 5 years in order to meet all of these regulations. We are staying in the business. We have the broadest cannula product line today, the largest cannula product numbers, the largest number of different categories of cannula, and we intend to be in all of those categories of cannula going forward. So we are making that commitment. Okay, so cannulation for minimally invasive cardiac surgery, and please feel free to even step to the mic or raise your hand and ask questions as we go through minimally invasive, because I'm going to ask you to raise hands again. So how many of you have been supporting cases where they are doing thoracotomies for mitral or even anterior thoracotomies for aortics, mini sternotomies with femoral cannulations? Okay, so it's becoming very, very common for lone valves or even double valve procedures, and also other concomitant procedures. So certainly in the valve space, that's what's happening, and so we're seeing a great deal of the small incision, what I would call small incision direct visualization. So this is not robotics, and robotics procedures I think have certainly gone flat in terms of numbers, and probably declining in terms of numbers for cardiac surgeries. The exception of that would be in Europe and a couple of centers in the US where we still see robotics growing slightly. But in place of that, many surgeons who did learn robotics techniques have found that it's very simple to do a very similar type of a small 3, 4, 5 centimeter incision, sometimes smaller, through the chest, through a thoracotomy, but using long instruments. So we would call this direct visualization small incision procedures rather than robotics. I think that skill set is very similar, but it does not require the same level of capital equipment commitment, obviously, as a robot. Revascularization for beating heart. So there are some centers starting to do more beating heart through small incisions on the left side, so rather than a full sternotomy. And so we're seeing more minimally invasive procedures this way. Some centers are also combining this with the right-sided, doing stenting on the right side. So they may do a hybrid procedure, perhaps even in a hybrid room in some centers. How many of you are working where they do have hybrid centers and are doing combined procedures like this? Is that a fair description of what's happening with left-sided vessels and then right-side stenting? Okay. And then surgical ablation. Probably not as commonly done through minimally invasive, but there is, of course, both thoracotomies or bilateral thoracotomies being done for surgical ablation procedures. And so, of course, for the heart valve procedures and the surgical ablation procedures, those are areas where you would have cannulation going on, and femoral cannulation to support that, and peripheral cannulation. So this illustration, this photograph on the right, you can see how small the incision is in that OR picture on the right. This is actually a surgeon who completely started his experience doing small thoracotomy mitral valves as a robotic surgeon, and has now completely switched over to doing direct visualization. So as you can see that the incision remains quite small. That is actually the smallest size of the retractor, of the soft tissue retractor in that position. So femoral cannulation certainly avoids having to go with cannula through that small thoracic incision, most commonly for femoral arterial and femoral venous by Seldinger technique, cut down, or percutaneous. I say that also another comment here is that many surgeons doing these techniques for valves often cannulate femorally on the left side rather than on the right. And the reason for that is that most of these patients have been cathed recently on the right, and so there's reason to not go back and redisrupt that tissue on the right side. And I think this is another very important piece, is that positioning of the cannula is very important, especially for venous drainage. It's very critical. And so on the left-hand side, and we do have a video online, I'm not going to show it because I'm having difficulty switching to videos on my computer today, but there is a couple of videos that we offer online of different surgeons demonstrating their technique for femoral venous cannulation. In both cases, they're using cannula that are longer, 60 centimeters in length rather than 50 centimeters in length, so they are intended to have the tip placed all the way up into the SVC. And that requires that first, the guide wire is placed all the way up into the SVC. And so the important piece there is you must be able to see the guide wire on the bicaval echo view. And you can see this in this, I don't hear you have a laser. Can't work that. You can see that on the echo image on the left, the top image, there's a very straight line going across there. That's the guide wire. Nothing else will be a straight line in the right atrium in the bicaval view. And so if you don't see that guide wire crossing and going up into the SVC, you don't start placing the cannula over the guide wire. Because if you don't see that guide wire up there, many surgeons who do these procedures frequently will acknowledge that occasionally when they can't see that guide wire, the guide wire has taken an excursion into the hepatic veins in the liver. And so you absolutely must see that guide wire up across the atrium and into the SVC. And most surgeons who do this will also say, place the guide wire very high. In other words, place the guide wire high enough that you probably have the end of the guide wire actually in the internal jugular at the end of the SVC. That gives you the ability then to femorally cannulate and place that in a higher position. You may or may not be able to see this on the slides, but there is a femoral venous cannula in a silicone model on the photographs on the right, and that shows where the innominate vein joins the SVC above the atrium. Interestingly, if you look at the anatomical data, we've looked at university anatomical data as well as Air Force data. They have extensive databases on anatomy and sizing of the vasculature. The length from the SVC atrial junction and to the innominate is fairly consistent, regardless of patient height. So on most adults, we're looking at about 3.5 to 4 centimeters before you have the lower edge of the junction of the innominate vein entering the SVC. That's much farther than even anesthesiologists who place things in the neck all the time expected that junction was. And so it's interesting to take a look and see that. And in this silicone model, it's nice to see that tip goes up there. What that means is when you're placing a venous cannula up in the SVC, you can usually, with the echo view of the right atrium, you can usually have them switch to an X-plane and maybe see about 1 inch, about 2.5 centimeters up in the SVC. But you really want that cannula more like 3.5 to 4 centimeters. And so because of that, you do want to make sure that the placement is high in the SVC. It's very easy to reposition that cannula slightly lower if the drainage is not optimal once it's placed and you're on pump, but it's much more difficult to place it higher because they would have to actually feel and palpate that SVC to place it higher. So has anybody experienced this and with venous cannula being placed and having to reposition? So it's actually quite a common issue, and I think it requires, number one, that the surgeons understand the position needs to be very high, and number two, moderate levels of vacuum, because greater levels of vacuum will exacerbate the issue and pull vessels to the sidewall, the side holes of a cannula, no matter which cannula you have in there. And another very important technique for femoral cannulation for arterial is to have a long arterial cannula that allows the tip of the cannula to be beyond the bifurcation. So if you look at the illustrations here on the left, the illustration shows that the cannula, of course you're going to have your insertion point at the groin, and you want the tip of the cannula to be long enough to go beyond the bifurcation so that the outflow of the tip is directed directly into the aorta, the descending aorta. And this allows the outflow to be entering a larger vessel, which has a larger volume. And therefore, the outflow meets less resistance. And by that, you end up with sometimes as much as 20% lower arterial line pressure than you would normally expect. If you have the cannula down in the femoral artery, you're in a smaller vessel, that's when you'll have the higher arterial line pressure. And of course, the absolute worst case scenario is to have the tip of the cannula at the bifurcation, so that the outflow is against the wall of the vessel at the bifurcation. That's why femoral arterial cannula all have side holes, because the risk of having that tip right at the bifurcation so that the end hole is obstructed is actually not that uncommon, depending on patient height and vasculature. So you end up with then needing side holes, and that's why There are cannula that are elongated and intended as arch cannula that sometimes people would like to use as a femoral arterial cannula. Those are not indicated for that and should not be used for that because they have no side holes to allow you to reduce the arterial line pressure if your tip is obstructed. But our femoral biomedicus cannula, as well as our new next-gen biomedicus cannula, all have 18 centimeters of insertion length. And the purpose of that is so that we always make sure that the tip is in the aorta and has made it beyond the bifurcation. Most femoral cannula on the market, other than biomedicus, actually have only about 15 centimeters of insertion length. And this is another illustration and an image inside the vessel showing an jugular venous placement. This is also commonly done. This is something that you used to see and still probably do see in many of the robotics procedures. So the surgeons who did minimally invasive by robotics techniques and now are doing them by direct visualization with long instruments will very commonly sometimes put a jugular in and a jugular venous then, so you essentially have a bicaval cannulation, one femoral cannula just up to the junction and one in the jugular. Our biomedicus next-gen arterial cannula is actually an arterial or jugular cannula. So it actually has an indication and was submitted to the FDA and cleared as a femoral arterial or a jugular venous cannula. And we also offer those in larger sizes than we used to. This gets into just showing a couple of illustrations of the insertion method for the jugular. Again, that 18 centimeter insertion length can be very useful depending on patient anatomy and size even of tissue that you're going through at the neck in order to place that and how high up the neck you need to place that. It allows you to have the tip not just down to the innominate vein, but actually down to the SVC atrial junction if you choose to do so. And I'll cover a few quick points about our biomedicus next-gen. This product's been out for a few years now. It is probably gaining a great deal of popularity, certainly on the arterial side and also the pediatric side. The venous cannula is designed to be a bicaval cannula, and so that is very useful for these minimally invasive techniques. Could I see a show of hands of centers that have used our next-gen? Is anybody? Several? Okay, thank you. The big differences here are things that we really had been told by the customers, the surgeons, as well as perfusionists, needed to change from our old biomedicus. Our old biomedicus was actually designed originally about 28 years ago. While it was very, I think it was very innovative at the time, and certainly the thin wall urethane was a great benefit in the manufacturer style, there were many features on it that over the years could have been improved, and so the next gen allows us to do that. The tipping in the top left there really shows that the tip of the cannula and the fit of that tip to the introducer, it hugs the sidewall of the introducer much more tightly than our biomedicus original and also than any other femoral cannula on the market today. There's little reinforcement fingerlets at the tip that allow us to have that tip be very tight to the sidewall. So you now have a very smooth transition when you enter and go through the vessel wall into the vein, into the artery or the vein. Also, the side holes on the cannula, because of the reinforcement of the tip, those side holes are now in an area where the edge of the side hole is no longer an abrupt edge, as it was with the non-wire wound tip, but it actually has a bit of a radius on the edge of it. So for surgeons, when they remove these cannula and they're pulling down the purse strings tightly, this does not catch any longer. It used to catch sometimes on the edge of that side hole. And so this is also something that the surgeons very much appreciate. In addition to that, there are a lot of other changes. If you would like to discuss some of the other changes in the product, I'd be happy to talk with you at the booth and come over there and see me as well. Before I leave this slide, one more thing I think that's very important is on the pediatric models, we actually have now two introducers in the package. So there's an introducer that's like our old one with a solid core, no lumen for a guide wire, and also an introducer that can be placed percutaneously over an 025 guide wire. So that's something that we've added to the next-gen pediatric models. Flow performances are essentially the same. The wall thicknesses on the cannula are thin as they were with the original biomedicus. And I'm going to leave you with one more comment of things I'll be happy to talk to you about over in the booth, and that is that we are very pleased to be now announcing that we are releasing and distributing a product that is a new dual lumen jugular ECMO cannula. So this is interesting because it's actually under the FDA's new process and changes. This is the first product that's being released that has gone through the FDA clearance to be a individually indicated for ECMO product. As I mentioned to you, none of the other products we talked about earlier are indicated for ECMO, and I can never recommend our current products, original products for ECMO. This product I can. And it's a dual lumen, and it is a jugular cannula. It is being introduced formally at the ELSO meeting this week, another day or two. We are very limited right now in our centers that we are rolling this out to. We have 5 centers that have currently begun using this cannula in the last couple of weeks. It's been very successfully and very well received. It has a number of feature changes over the dual lumen jugular that you may be familiar with if you're using a VV jugular venous cannula, and I'd be happy to show you those over at the booth as well. Could I just get another quick show of hands? How many of you do VV with a jugular? Okay, good. So that's definitely, certainly something that will be of interest to you. And with that, I guess I'd open it up for any questions. Yes?